Well, sorry to break up the travel conversation, but let's get started because we want to cover material. And Friday is going to be a quiz, so I probably will do like I did last time and just have the quiz because it's 25 questions. Couple of announcements. It's 1 week official. All right. So we got today, Wednesday, Friday, and then the following Monday. The other thing is I thought I updated this the last lecture when I finished the immune chapter, but apparently it didn't. I updated the blank flow diagram and the key, make sure yeah, it's definitely blank. But the key I did in type instead of handwritten because there were some things I tweaked on it. It's still pulling up the handwritten notes. So I'm going to try and fix that today after class for the immune system, the sequence right here. And then the other one is basically the categories. All right, but I guess that's down. So definitely have them separate. So if you see this combined one, that's not the current one. I'm going to try and get that posted, but I don't know. You're probably not studying that right now. You might be studying respiratory stuff because the quiz on Friday. So don't forget about that. And also on Friday, if the quiz stressed you out at 12 to 3, puppies are going to be on campus. Let's hope it doesn't rain. Okay, so we're going to have that for the pause for pause. And I keep thinking there's something else I wanted to remind you of, but oh, I can't remember it right now. So any questions about that? Okay, so let's pick up where we left off. So the people who are in anatomy in the class that's just before this one, are you covering endocrine system? Is that what? Okay. Sound familiar? Okay. In fact, actually a little more detail. What is an upper? Well, that's anatomy. Yeah, that's good though. I'm glad she's covering that. So many people don't. Huh? Oh, good. Fantastic. Okay. Are you going to give me trouble again today? No. Okay, so Friday we talked a lot about the male reproductive anatomy. It was review. And then I talked about some things while I had that slide up there, like prostate exams and preemptive screening and things like that. And I kind of went off topic, but it's okay. So continuing on with male reproductive stuff, we'll finish this today and get into female reproductive anatomy. So here is a cross section of the testes, and this is the epididymis, and that's part of the vas deferens. They're just calling it spermatic cord. So the testes are obviously from anatomy. I assume you've had this, paired gonads, and they contain, and this you might not have covered in anatomy, testicular lobes. So that's a lobe, that's a lobe, that's a lobe. And within these testes, you have highly coiled, it's frozen again. There we go. At least the mouse works. You have seminiferous tubules, which are super coiled tubes. And within those tubes, that's where the sperm production happens. And this does not show the extent of how coiled they are. But if you were to stretch the seminiferous tubules, both of them, both testes, end to end, they probably stretch the length of a football field. So that's a lot of surface area because at puberty, men are producing sperm every single day, millions of them. Okay. It's a little different for women at puberty. We ovulate at most one egg. Well, maybe at least. Some people might ovulate too, but obviously that's a greater reproductive capacity. And so within one seminiferous tubule, if you cut that in cross section, this is what it looks like. And there's a reason why I'm going over this. So you'll have 3 sets of specialized cells. All right. The first one are spermatogonia, which are these clusters of cells here. And that is where sperm are produced. So meiosis, introbio, right? You go through meiosis 1 and meiosis 2, and you go from diploid parent cell. At the end of meiosis, you have haploid daughter cells, even though they're still called daughter cells, even if they're sperm. Okay. So what's diploid mean? Just curious. 2 sets of chromosomes, one inherited from mom, one inherited from dad. So that's what you got here. By the time they finish meiosis, they're haploid sperm cells. They only have 1 set of chromosomes. All right. And then if this sperm cell merges with an egg cell, the 23 chromosomes here will merge with an egg's 23 chromosomes. And then the developing zygote will have the 23 pairs again. Okay. So those will become sperm. Sertoli cells are these cells in between, and they respond to pituitary FSH. And if you remember from endocrine system, FSH helps in sperm or egg maturation. That's what it does. So we don't know exactly how it's doing it, but it's helping these go from this to that. And then leydig cells on the outside, they're kind of called interstitial cells. They respond to pituitary LH. And so do you remember what pituitary LH causes the testes to do? I already said FSH causes sertoli cells to help with sperm production. What does LH cause to happen in the testes? Oh, it's too far back, right? It's endocrine system. Anatomy people who are covering this. Did you cover this yet? Testosterone. Testosterone. Okay. I know some of this stuff you just push to the back of your brain. Okay, so now let's do this one step at a time. We'll write it all out. So sertoli cells, let's get my pen, respond to pituitary LH. Oh, sorry, FSH to help sperm production. So they've all got specialized, and I've color coded it. The red goes with the red. And then next, the leydig cells respond to pituitary LH to make testosterone. And then the last one, spermatogonia, go through meiosis to produce haploid sperm. Right. So these cells are active from like when a baby's in the womb, when it's still a fetus. These leydig cells are actively producing testosterone. So that's why a developing fetus is born masculinized, because they're producing this their entire lives. All right. From birth to, well, actually from 8 weeks of development on, and then all throughout adulthood. Now, these cells and these cells don't do anything until puberty. All right. So one's active all the time and the other only turns on at puberty. Okay. So more anatomy. So the epididymis is this structure right here. All right, a little comma-like structure over the testes. It is where sperm mature. Let's move this thing out of the way. Before ejaculation. Oops, come back, pen. So that epididymis is kind of like a sperm warehouse. I like to think of it that way because a warehouse contains a product that is eventually going to be shipped out. And so that's exactly what the epididymis does. It takes the sperm that are produced in the seminiferous tubules of the testes, and then they move up into the epididymis, the warehouse, sperm warehouse. They go through a little more maturation. I'm not going into that detail. And then if there's an ejaculatory event, they go from there, they go up the vas deferens through the ejaculatory duct and out the urethra. So I like to think of it as a sperm warehouse. Now the scrotum, it keeps advancing because I'm touching my screen, houses, why not say that, the testes. And what is the significance of the testes being contained within a sac that's outside the abdominal cavity? Keeps the temperature lower. All right. So houses the testes and keeps sperm about 3 degrees lower than body temperature. Why is that important? If you learned that, I assume from anatomy, why is that important? Did you get that part of it? The sperm is temperature sensitive. Okay, if the testes were to be retained in the abdomen, the sperm would not mature correctly. They'd have problems. Okay, they need to be about 3 degrees cooler than body temperature in order for the correct morphology of the sperm. Now, we're going to talk about what happens when a baby's born and one or more testes are retained. And that's actually pretty common. Okay, let's back up to the cremaster muscle. This is the muscle. It's right here. Oop. I don't know why that did that. Back, escape. Doing all kinds of weird things. Okay, let me just go back to this. Okay, there we go. Weird things when I'm connected to this projector. The muscle right here, shown in kind of, I guess, red, that lifts and lowers the testes. Now, the reason the cremaster muscle is needed, because if it's particularly cold out, then the cremaster muscle will contract and pull the sac with the testes up against the abdominal wall and it'll warm them up. If it's really, really hot, the muscle will relax, and so the testes will dangle farther away from the abdominal wall. So it's temperature regulation. That's what it's important. The spermatic cord is right here, and it actually comes through the sheath of connective tissue. And it is basically, the cord is surrounding the penile arteries, veins, and nerves. And of course, that also surrounds the cremaster muscle and things like that. So the significance of me including this is during fetal development, I think I'm out around month 7. I think that's right. The testes are in the abdominal cavity and they descend through this inguinal ring into the scrotal sacs. So when a baby is born, the testes should already be in the scrotal sac. There are going to be situations where your baby's going to be born and one or both testes hasn't descended yet. Remember what I said, babies come out, they're not fully cooked. They don't intervene immediately. They might give it a month or 2. All right. But then if the testes haven't descended by then, they're going to have to intervene. And here's why. Testes that are left retained in the abdomen cause altered meiosis. All right. And that could become cancerous. If a testes is retained in the abdomen, it is at high likelihood you're going to get testicular cancer in that testis. So they have to come out. All right. So that's something you're going to see. They won't necessarily intervene. It might give it a little time. I know this because I rehabilitate animals. I raised a little deer once, a little fawn. It was, kind of newly born. And it took 3 months for its testes to descend. All right. It was okay, but it came out and there was nothing in the sac. And I talked to the vet. She said, "Oh, just give it a little bit of time. They'll come down." And they did. All right. Same thing with humans. We're all animals. So that inguinal ring right here is an opening through that ligament, which the testes can descend around. Oh, yeah, I was right. 7 months. Now, after the testes have descended, that inguinal ring is supposed to narrow down a little bit, not close off, but narrow its opening so that the testes can't migrate back up through that ring into the abdominal cavity. And with the ring being narrowed and once you're born, intestines that would be lying right here can't go down through that inguinal ring. So have you heard of an inguinal hernia? Very, very common. Okay. Sometimes a very talented doctor, physician assistant, or even nurse can actually palpate that some intestine is poking through that inguinal ring. And sometimes they're pretty good about manually pushing that intestine out. But if someone's prone to having an inguinal hernia once, they're prone to having it again and again and again. What would be the problem if either the spermatic cord and everything it surrounds goes backwards up, or intestine goes down into that inguinal ring? Why is an inguinal hernia something you just kind of want to make sure to take care of? Be brave, be confident. It might get pinched off. Exactly. So if things go up or things come down into that inguinal ring, especially with abdominal pressure, it can pinch off that tissue, and now it loses a blood supply and that tissue could die. And that would be a big problem. So you can't let an inguinal hernia just go on without being treated. So another term, anyone know what the term cryptorchidism is? Because maybe you learned it in anatomy, because it's common. It has to do with something I was just talking about. No? One or both testes retained in the abdomen. And it's common enough that you're going to see it Abdomen, that's an M. There we go, abdomen. So it'd be good to know what that term is, because if you hear it thrown around in hospital, yeah, that means one or more testes are retained, and you can kind of take a wait and see in a young baby that's born. If you ever see an adult with that, you need to talk to the doctor and say, they've got one testes that's retained. They know this. They have to go to surgery. You have to get that testis out of the abdomen because it's prone to becoming cancerous. And how are you going to know if cancer is forming in your abdomen? You're not, unless someone knows that you're at risk for that cancer and they scan you. Okay, but you're going to see them. You're going to see these things. So this is what an inguinal hernia where the intestines pops through is, okay? So yeah, that's not good to have some of your intestine pinched off in the inguinal ring when part of that intestine could die, and that would be a problem. Okay. Okay, transport tubes. I talked about them, but I didn't write anything down. So the first transport tube is right here in red. It meets with the epididymis down here, and it goes around the outside of the bladder. I'm having allergies this morning, so my voice is a little rough. And then it meets with the ejaculatory duct. So it is the first and longest sperm transport tube. Okay, I don't know why I needed 2 lines for that. I guess I thought it was going to be more wordy. The next is the ejaculatory duct, which this does go through the prostate. The vas deferens doesn't go through the bladder. The image is a little misleading, but this does go through the prostate, which is that little pink circle right there. So this is the tube that passes through the prostate. Oop. There we go. And then, of course, the last tube is the urethra, which transports either urine or semen, but not at the same time. And why is it important that it's not at the same time? Acidic urine will kill the sperm. And so I know last time I was talking about the sphincter that can close off the bladder. I talked about during a sympathetic ejaculatory event, this sphincter right here, all right, proximal sphincter, I put in black, closes off so that no urine can enter the urethra when seminal fluid is coming through. Now, it's probably on the slide. Yeah, it is. So a vasectomy. I mean, I feel silly asking you this because it's almost like common knowledge, but what's a vasectomy? Yes. They snip the vas deferens, both of them, to sterilize a man. So cutting, often followed by clamping or cauterizing, yes. The vas deferens. Now, it's meant, so people are going to come in, men are going to come in and they're going to be wanting to have a vasectomy, which is not, it's basically, it's an in-clinic procedure. Has anyone ever seen this done? I think they do give a sedative, so a person doesn't move around a lot because you don't want that to happen, and that's pretty good. But basically, and I don't think I didn't put a video in because, but anyway, they cut an opening in basically they go through the skin. They lidocaine it first, okay? And that numbs the area. And then they cut through the skin and they fish around, they find the spermatic cord, and then they slice through the spermatic cord and they tease out among the blood vessels and the nerves that vas deferens. And then they're gonna ligate, or, you know, I said clamping. And they use clips now. Before they used to use suture and tie the ends off like above and below. They'd make like one clip here or sutures there, and then another one there. All right. And then in between, they'd cut or cauterize. All right. Now, if someone comes in and they're talking to you and you're the nurse and you're getting the patient history and getting information about them, you must let them know that this is a permanent sterilization method. I know you can get a vasectomy undone. You can undo a vasectomy. Not so much if it's cauterized, because then you've singed the ends of the tube. but it's still possible. They could cut away the singed tissue and try and reconnect the two ends together. But you have to make sure the patient knows that this could be permanent, even though they could reverse it by bringing the two sections of the tube together again, suturing it all together. If they formed a bunch of scar tissue inside that tube from the first procedure, it might be null and void. It might be permanent. So yes, vasectomies are known to be reversible, but if there's scar tissue, it might end up being permanent. So they need to know that they can't reverse it possibly. All right. Okay. Well, that's kind of what it looks like. This is when they had sutures. They now use clips, or they can cauterize. Well, they can cut in between or cauterize, but they do keep these stainless. I don't know. They're titanium. There's something that the body won't react to. The clips are non-reactive, so the body doesn't mount an immune response to them. Okay. So you're going to see that. It's fairly common. Okay. The secretory glands, 3 of them. So the seminal vesicle, which is this thing right here, there's 2 of them, a left and a right. They contribute the fluid component of semen, because up until this point, when they're traveling through the vas deferens right here, it's just sperm, maybe a little bit of a liquidy mucus stuff, but that's it. When they pass by the seminal vesicles, it contributes these 3 things, which I mentioned last time, but I didn't write them down. It produces prostaglandin. What did I say prostaglandin does? Because I didn't write it down. I was just talking. Yep, it causes uterine contractions. Causes uterine contractions that they think might aid the sperm in their journey. Once they're deposited in the vagina and they get through the cervix, contraction of the uterus might help move them up closer to the fallopian tubes where they might meet an egg. The other thing the secretory gland, the seminal vesicle produces is fructose, which is a simple sugar. And I'll say for energy source. Because the sperm got a long way to travel up the uterus, up the fallopian tube. They're microscopic things. That's a long journey. All right, that's a marathon for them. And it also produces alkaline mucus. And why is that important? Why is it important that the mucus that's in seminal fluid is alkaline? The vagina is acidic. So to counteract vaginal acidity. Now, the vagina is acidic because it has lactobacillus bacteria, and it produces acid as a byproduct, and it's actually the good bacteria for the vagina. The vagina being acidic is part of the barrier of the immune system. It would kill bacteria if it gets up in there, okay? But if you're a sperm cell, you need to have that counteracted so you can make your journey. The prostate gland just secretes mucus, all right? Doesn't contribute a lot to seminal fluid, but it does contribute a little, but you can live without a prostate and you can still be fertile, because really what you need is the seminal vesicles. And then the bulbourethral gland, which looks like a little push pin right here, is producing a lubricant during sexual arousal. So that's what's called the pre-cum, all right? I know, how can she say that? Well, I can, because I'm a biologist and I'm a reproductive biologist. So I can say it. It's the pre-cum. And I was talking last time, if there is still seminal fluid in the urethra, and then the bulbourethral gland produces the lubricating mucus, it can push that sperm to the head of the penis. So if people are goofing around, the man doesn't necessarily have to ejaculate to get you pregnant. Are the chances high that the pre-cum contain enough sperm to get a woman pregnant? The chances are low, but it's not impossible. All right, just saying. So that's something. Okay. So speaking of the prostate gland, and I was talking last time, but now we'll have it written down. Benign prostate hyperplasia is non-cancerous growth of the prostate with age. This is a normal thing that can happen when men age. The prostate can grow. Now, a person could go through their whole life with a prostate that's a little bit enlarged and have no problem. But like in our case study, like the thymus hyperplasia, what did that put the thymus at risk of? Being hyperplastic. Cancer, all right? Benign prostate hyperplasia can become malignant prostate cancer, all right? So prostate cancer, malignant means it's cancer. Benign means it's harmless or non-cancerous, all right? Now, and so what's the significance of, well, anyway, when a man gets to a certain age, I think starting around age 40, certainly by age 50, and definitely if they have a family history of prostate cancer that you get from them in a patient history. You could have a patient come in for a regular health check and you're getting the patient history, maybe asking some questions, and it happens to come out that, oh, my father had prostate cancer. Oh, my uncle has prostate cancer. Oh, my grandfather does. My brother does. Oh, okay. I think today, based on their age, if they're around 40-ish, I think today as part of your exam, you should have your prostate examined. And this is a very good thing. But your patient, like, no. You need to talk to them about this, saying, you have a family history of this, which we know there's genetic links to certain cancers, and this is certainly one of them. And a prostate exam, we need to keep a regular checkup on you to make sure that prostate is normal. And they're gonna resist you on this, okay? And this is why you got to become a good advocate for your patient, because there's a chance that they could get this prostate cancer too, because it's in the family. And so because of the anatomy, the only way to feel the prostate is for a gloved, lubricated finger to go up the rectum, feel the anterior wall, and you'll feel the prostate. And it should not be lumpy and bumpy. And someone who's experienced at these prostate exams would know roughly how big the prostate should be in a man, okay? But that is something that should be part of every man's wellness check. And if they don't have a family history, then maybe they don't need to get it every year, maybe every other year. But if they have a family history, that better get checked every year. Because if there is cancer and it's not detected, and the cancer spreads, metastasizes, and gets into the lymph system, which is the highway through the body, then your survivorship goes down dramatically. If you catch it early and treat it, survivorship goes up. All right. So common tests for prostate cancer is PSA. It's a blood test, prostate specific antigen. When it's high, it is associated with an increased risk of having prostate cancer. It doesn't mean the person has it, but pair these tests, someone with a family history of prostate disease, prostate cancer, get the prostate examined at the wellness check, and then also maybe every other year do a PSA test to see if that antigen is rising or if it's within normal levels. And if they get that prostate examined and it seems to be abnormal, you can have a biopsy. Or before going to biopsy, because that is kind of invasive, you can get a genetic test. They draw your blood, but it's a genetic test for the BRCA gene. Anyone hear of the BRCA gene? Anyone? It is a kind of a new genetic test, maybe the past 20 years, So it's not well known. I have a mutation in the BRCA gene, which made me at risk for ovarian and breast cancer. Obviously, I don't have my breasts anymore because I had the mutation. I got breast cancer. All right. If a man has the mutation in the BRCA gene, they have a 30% increased risk of prostate cancer. That's pretty high. That's pretty significant. So if someone says they have a family history of prostate cancer, they go in for their wellness check, they get a prostate exam, and it feels abnormal, going to do a PSA test. And if they have insurance, because it might be several $1,000s, maybe look for mutation in the BRCA gene. If you have both the antigen high and the mutation, they're going to want to do a biopsy, because that is an increased risk of that abnormal prostate being cancerous. And if it is cancerous, you can treat it. If it's early stages, you can do chemotherapy and all that stuff. But if it's kind of advanced, and pathology will tell with a biopsy, you got to take that prostate out. You can live without the prostate, all right? Because you don't want that stuff to get into the lymph system and spread all over the body. So yeah, men are going to be resistant to this idea of prostate exams. But if they have a family history, make sure, future nurses, you push for this, because you might be saving a life by making sure to catch that early. Okay, so prostate cancer commonly tested using the blood test PSA, and it's not that expensive, so that's an incentive to get it done. More common disorder is benign prostate hyperplasia. It can be no problem, no cancer, but because the tissue is growing, there's always a chance in mistake in meiosis that can lead to cancer. All right. And so there's different ways to treat it. Oh, look at this. I'm not going to require it of you in an exam, but look at that alpha adrenergic receptor blocker. Okay. Let me take you through this. When the prostate enlarges, there's two tubes running through it, the urethra and the ejaculatory duct. Someone who has BPH, and if it's pretty swollen, it might pinch the urethra, narrowing it, making it hard to urinate and empty your bladder. And it could also pinch the ejaculatory duct, making it difficult for seminal fluid to pass through during ejaculation. So a man with BPH could have two possible problems, or three. They could have difficulty emptying their bladder because the urethra is narrowed, and they could have difficulty fathering a child because seminal fluid's not getting through because both of those are pinched by the growth. Now, what they're talking about here is if they're having a hard time peeing. Remember we talked about the proximal urethral sphincter is not under control, and under parasympathetic control and ACH, that urethra can open up and allow urine to pass, but under sympathetic control, it causes the urethra to pinch shut. One way to keep that urethra more open is to block any sympathetic effect by alpha adrenergic receptors. Follow me on that? I'm not going to ask you this on an exam, but those receptors and the blockers and agonists, don't let go of that stuff. You're going to see it again and again in nursing. Okay. All right. But that's enough about that. Okay. So more anatomy review. So here's the penis with the spermatic cord peeled apart, and you can see penile veins, arteries, and nerves. And here is a kind of a cross section through the penis, and the big blue, it's not really colored blue. On the left and the right is the corpus cavernosa. And here's an arteriole going through. Down here is the urethra covered by the corpus spongiosum. And I always think it looks like a face that's doing this. Huh? Okay, it's kind of funny. Maybe not for a Monday, okay? But anyway, the corpus cavernosa, during an erection, blood is going to come in through those arterioles and fill the chambers with blood. And then the blood's got nowhere to go because the veins will clamp down. And as that fluid, that blood fills the chambers more and more, fluid's got no place to go. It builds up tremendous pressure, and that's what causes the erection. It's a hydraulic event. Now, the lining of these arteries has an endothelium. And I'm going to get to an erection, how it happens, the physiology of it. And then once you know the physiology of how an erection occurs, you will know when the people have erectile dysfunction, how the drug works. And it's like the #1 prescribed drug is erectile dysfunction drugs for men. So you have to know how it works, an erection. So during sexual arousal, nitric oxide, which is a gaseous messenger, and I think I covered this in the endocrine system, fills the corpus cavernosa. The nitric oxide causes production of the cGMP, and I've got it in bold blue because that's what I want you to know. The cGMP causes those arterioles, arteries going through the corpus cavernosa to vasodilate. All right. They vasodilate, allowing blood into the chambers, and that's what causes the erection. cGMP does by causing the arteries to dilate. Now, the pressure that builds up causes the erection. When the stimulation is done or ejaculation has occurred, you've got to get that cGMP out. Okay. You need those arteries to vasoconstrict down again. And you need the blood to leave the penis so the erection ends. So there's an enzyme that breaks down the cGMP. It's called phosphodiesterase. So it breaks down cGMP. Okay. So the erection ends. The blood leaves the corpus cavernosa and the erection goes away. Now, there's major two things that can cause erectile dysfunction. It's going to be a common thing. #1, are they going through something psychologically, emotionally, something like that? It could be the problem up in here. All right. So you have to rule those things out. It could be, do they have some sort of heart disease or vascular disease, things like that, that can affect blood flow in the body? That could be it. It could just be they have a problem with maybe there's not enough cGMP or something like that. Could be a blood flow problem. So if it's not psychological or other health problem involved, then you can promote more cGMP by giving them erectile dysfunction drugs like Viagra, Cialis, Levitra, and what other formulations are out there. Okay, so blah, blah, blah. CGMP causes the smooth muscles of the artery to relax. They vasodilate, blood flows into the corpora cavernosa chambers, and you get an erection, right? This enzyme breaks down the CGMP, so the erection goes away. Viagra, Cialis, Levitra, whatever, work by inhibiting phosphodiesterase. They're a phosphodiesterase inhibitor. And so if you don't have that enzyme breaking down the CGMP, CGMP is building up and you get an erection, and you can get and maintain an erection. All right. So I think I have a little flow through. So phosphodiesterase inhibitor is what Viagra, Cialis, Levitra, and all those others work by. So if you give a phosphodiesterase inhibitor, what happens to CGMP? Go up or down? Up. More CGMP causes more artery vasodilation. And that causes an erection. Okay. Now, there is a side effect of taking these drugs. If you've ever seen the commercial on TV or heard it on the radio or seen it on YouTube, wherever, however you've heard about it, and they usually say after the drug, right, real fast, right? But if you listen, they'll say, if you, so as a nurse, you're spending more time with the patient. They've just been prescribed Viagra, little blue pill. All right. Make sure and talk to them about possible side effects, because some of them could be dangerous and they need to pay attention to it. So you need to, it's in the package insert, but no one ever reads the package insert on a drug. If you experience dizziness, loss of vision, or a drop in blood pressure, you get dizzy and feel like you want to pass out, that person needs to contact the doctor. Okay. Doctor's office. They might need to go in. Okay. So Viagra is a phosphodiesterase inhibitor. It increases CGMP, which causes artery vasodilation. Do you think that drug is just going to hone in on the arteries in the corpus cavernosa of the penis? You pop the pill, it's now in your bloodstream, right? Could it cause other arteries in your bloodstream to vasodilate? Yes. Okay. So if a person already has low blood pressure, this could cause them to pass out. Okay. If they are taking those nitrous tablets for heart disease to keep their heart's arteries open and wide, you got to be careful when you're taking this drug, because they're already taking something to keep their heart arteries open for cardiovascular disease. And if they take another artery vasodilator like this, you could have problems. And the loss in vision is you're losing blood flow to your brain. Okay. Now, so that's a side effect. And depending on the patient, it might be a significant side effect. Now, anyone know what priapism is? It's when the erection lasts longer than it should. So priapism is a very dangerous condition where the erection lasts longer than a few hours. I'll say 3 hours. Okay. So someone gets Viagra because they're having a hard time achieving and maintaining an erection. And now they've got an erection that's lasting for 3 hours. That's going to be, they're going to have a lot of fun, right? No, the penis tissue can die from pressure necrosis. It's not fun. It's painful. It's got to be fixed immediately. So you need, as a nurse, to say, if you end up having an erection that lasts longer than maybe 2 or 3 hours, that's an emergency. You need to call, you need to come in. Okay. And you know what they do to fix that? I know this from a student who volunteered at a hospital who was aware of it, seen it. It's just like a hematoma. You got to get the blood out, don't you? Yeah. So they're going to go in. I hope there's sedation involved with a needle, and they're going to pull the blood out of that the corpus cavernosa to immediately relieve the pressure. Because if the pressure is left, pressure presses out, and the soft tissue around it gets pressure necrosis. And I assure you, that would be very painful. It's not a fun thing to have an erection lasting that long. It's going to be painful, and you can possibly permanently damage, the penis. So they need to know that's a danger thing that's associated with the drug. If they experience that, come in. All right. All right. So vocab. Gametogenesis. It's got the word genesis, and it's got the word gamete. Gamete. It's gamete. Oop, I don't want that. Production. And that includes spermatogenesis, which of course is sperm production. And oogenesis. It's not oogenesis, all right, which is egg production. And let me add, let me do this. Let me change production to maturation. That is actually more accurate. Okay. So from birth to pre-puberty, there's tons of spermatogonia in the seminiferous tubules, but they're not going through meiosis. When you're born as a girl baby up to pre-puberty, you've got all the eggs in your ovary you're ever going to have. But at puberty, one egg is chosen to proceed through the rest of meiosis to make a mature egg. Same thing happens with sperm cells. FSH stimulates them to start going through meiosis and to mature. Now, steroidogenesis is production of the main sex hormones, which is estrogen or testosterone. Okay, obviously testosterone for the testes and estrogen for the ovaries. Now, being an endocrinologist, I know that the ovaries actually produce testosterone first, and then immediately gets converted to estrogen by an enzyme. So, okay, and I bring that up for a reason. So we're going to first look at production of sperm, then we'll look at production of eggs, and we will have some very relevant nursing applications to that, believe it or not. Do not memorize this diagram. No, it's just there for visual aid. But here we have in the seminiferous tubule, spermatogonia. They're diploid, 2N. They got a copy of 23 chromosomes from mom, a copy of 23 chromosomes from dad. And then at puberty, you start going through meiosis 1. Well, first they duplicate. You remember from meiosis that the cells duplicate before they start the process. So you go primary spermatocyte. It has the word primary in front of it. It's still diploid. If it has the word secondary, it has now gone to a haploid state. And the same is true for eggs. If it says primary oocyte, it's still diploid. If it says secondary oocyte, it's now haploid. So it goes through meiosis 1, becomes haploid, and then it finishes meiosis 2 with spermatids, which these are actually what go into the epididymis, and then they mature into spermatozoa. They basically get a little mitochondria thing right here and a tail for swimming. That's what happens in the epididymis. All right. So if I were to ever ask a question on this, I might ask you which of these sperm cells is haploid, or I could say which one is diploid. And basically, if it says spermatogonia or primary spermatocyte, they're diploid. If it says secondary or spermatid or spermatozoa, those are haploid. So that is a question I typically ask on an exam. Now, ladies, we don't produce eggs every day. We certainly don't ovulate them every day. You got less production, all right? So here's what an ovary looks like. It's got an outer cortex where the egg matures, and then it's got, of course, blood vessels, and the inside's called the medulla, just like an adrenal gland. There's a cortex and a medulla. And here's what happens. So step by step, you have all these eggs when you're born. They're called oogonia. And at puberty, one of these, however many thousands of eggs you have, is chosen. It's like The Price is Right. Come on down. There was a reboot of that, and I always like to think of it that way. But one egg and the follicle that houses it, the egg is the blue thing, and the thing around it is called a follicle. So it's like a car in a garage, all right? Eventually, the car is going to leave the garage. The garage stays there, all right? It doesn't go anywhere, but the car leaves. Same thing with the egg. Egg is going to eventually be ovulated, but the follicle remains in the ovary. So that is the beginning. And then at puberty, you get an oocyte that is called a primary oocyte. It's still diploid. And the follicle is called a secondary follicle. The follicle is going through changes, okay, as the egg is as well. So this pocket right here is fluid, all right? It's fluid. At the maturest stage, this follicle now is filled with fluid, and here we have the egg, which is now a secondary oocyte. Since it's a secondary, it's haploid. It is ready to be ovulated. How does ovulation happen? An explosion. It's a miniature explosion in your ovary, okay? The fluid builds up in the Graafian follicle. That's what this is called. That fluid pocket gets so big and so big and so big that eventually it causes the pressure ruptures through the follicle. Not only does the follicle wall rupture, it actually ruptures a hole in the ovary. And so basically the egg's going, "Phew," it ejects it like that. It's a miniature explosion. I like to think of it that way. So what happens is that secondary oocyte is ejected, starts going down the fallopian tube where it might or might not meet sperm cells. And the follicle that housed it, the garage, doesn't go anywhere. It stays behind in the ovary and it becomes a corpus luteum. And that means body, corpus, and luteum means yellow. It becomes a yellow body. And it starts pumping out progesterone. Anyone know what the significance of progesterone is? Do I have it on the slide? Nope. Progesterone maintains the uterus for pregnancy. It's your pregnancy hormone. If you didn't have progesterone, then the uterus wouldn't stay in a pregnancy-friendly state. Every month during the 28-day menstrual cycle, when you ovulate an egg, after that egg goes floating down the fallopian tube, the corpus luteum makes progesterone and gets the uterus ready for a possible pregnancy. So it causes the lining of the uterus to thicken with blood and cells, and it makes that lining of the uterus ready for a fertilized egg to implant and begin a pregnancy. And then it proceeds to keep that pregnancy going. Some women have a problem with miscarriage because their progesterone levels aren't high enough. All right. Fortunately, you can measure this in a blood test. Okay. So if there is no fertilized egg that implants in the uterine wall, then what happens is the corpus luteum dies. So you ovulate mid-cycle, day 14 of your cycle. Day 15 to 28, and I know there's not 28 days in every month, but it is what it is. 15 to 28, that corpus luteum is pumping out progesterone, getting the uterus ready for pregnancy. And so that produces some of the symptoms of premenstrual syndrome because you feel bloated and everything. Well, your uterus is growing. And I don't know if I have a slide of it. No, let me see. I'll come back to this. Do I have it? Oh, I might not. I had a picture I got off Facebook one time of a uterus not under the influence of progesterone. It's about the size of a pear versus uterus under the influence of progesterone is 2 to 3 times the size. And so ladies, if you feel bloated, if you feel, it's because your uterus is going like that. Okay. And well, I'll pick up the rest of this on Wednesday. And don't let me forget to tell you about Mittelschmerz.